So we have the surgeon, Dr. Zafar Khande. He's an associate professor in the Department of Surgery, and he's going to demonstrate this case. That is a laparoscopic repair in a child of 6 years. She's a female child. She's having a bilateral hernia. Dr. Zafar.
Good morning, everyone. I welcome you all to OT1 of Government Medical College, SMHS Hospital. This is a workshop being organized today. We're calling it a Hernia Day. So we have in OT2, OT3, we are about to start a female inguinal hernia. She is presented on the right side and she's 7 years old. She's about to get intubated. We are doing it under general anesthesia. She's in a supine position. And we have a Stryker high definition console with us, and the ports we are using is all 5mm ports and all 5mm instruments, and the suture we will be using is a 30 Vicryl. So the first port will be an optical port through the umbilicus, and then followed by 2 pararectal ports of 5mm each. First of all, we'll be doing a diagnostic lab. We'll be looking at the uterus and ovaries to rule out any associated anomalies in this child. So once an anomaly, in any child we have to look for other anomalies, and once we confirm the presence of uterus and ovaries, that will rule out our disorders of sexual dysfunction. Followed by this, we'll be going and looking towards the deep inguinal ring. So whether we'll see the affected side first, followed by looking at the other side, whether is it unilateral or is it bilateral. So we'll proceed as recommended for the repair of the laparoscopic hernia.
Sir, what's the plan basically? Once you are inside the abdominal cavity, what are you going to do with the hernial sac?
See, what we are going to do with the hernial sac is, first of all, if the hernial deep ring contains any contents, so we will be able to reduce them. We'll be able to give head load to the patient so that entire bowel is removed from the deep ring and the pelvis is quite free. The bladder should be deflated beforehand only. So we will have a good clean area to operate. We'll be taking 5mm scissors and dissecting around the deep ring. So once we dissect around the deep ring, we are creating this raw area. Then we'll introduce a 5mm, through 5mm port, 30 Vicryl needle into the peritoneal cavity, and then we will start suturing. So we'll take the sleeve of peritoneum and suture it with the medial end of the deep ring. We'll be taking multiple interrupted sutures can be taken, or you can take a simple purse string sutures. Okay, that is how we'll be able to close the ring.
So that's great, sir. So meanwhile, our anesthesia team is preparing the patient, and till we start the case, we'll see what is being done in other ORs. So we'll catch you shortly, Dr. Zafar.
Thank you.
So this is the OR1 where we are planning a laparoscopic fundoplication. This is a patient of hiatus hernia. And we are joined by Professor Iqbal Salim. So sir, what's the plan here?
Good morning. Well, basically, this is an elderly female. She has gallstones, plus she has hiatus hernia grade 3. She is symptomatic for both. So we have decided to do both the procedures in one go, and we are planning the laparoscopic cholecystectomy with a laparoscopic nascent fundoplication. Once we go in, then we'll see what else. She also has a duodenal diverticulum that we have assessed, and we will see on table whether it needs any more treatment or we'll just keep it like that.
So what should be the plan? You are first going for cholecystectomy or for fundoplication?
Yes, first we'll do the cholecystectomy, then we will do a leg split, and we'll go in French position and do a lap hold.
So would you be using additional ports for?
Yes, definitely.
Okay.
Definitely, because naturally the fundoplication is on the left side of the patient and lap pulley is on the right side. So the ports cannot be interchanged.
So wonderful. Could you introduce your team, sir?
I have with me producer introduce yourself. So he's also my down.
Okay, so we have got two Iqbals operating on the same case.
And I have got Dr. Haris who is going to assist me He is my third year postgraduate scholar, and I'll be having Dr. Sajid. He is a senior resident. Okay, that's going to be my team, and we are going to use the power source equipment. That is image 1. Let's see. We'll try to do some justice today. Thank
Okay.
you.
Good to hear that. So we'll be catching it shortly. Once we join the live case, we'll be streaming it live. Let's go to the second OR2, and see what is there. So this is our OR2, where we are having good fortunes to see our anesthesia team here as well. Dr. Dawood is here from the anesthesia side, Dr. Mara is here. And this is Dr. Rifat, our consultant. What's the case? Oh, we are joined by my batchmate, Dr. Anka. So how can I forget her? Dr. Rifat, what's the case here?
She is a patient, around 75 years old female. She is hypertensive, diabetic patient. We selected the patient for the open surgery because of so many comorbidities, and it's very important for our postgraduates to do open surgeries also. So she is a case of supraabdominal hernia. We are planning to do open hernia repair in this patient. Likely we will do a right stopes procedure in this patient.
Okay, so this is a patient of M3, and we are doing a reeve stopper, open reeve stopper. Wonderful, wonderful. So meanwhile, once we start the case, we'll be demonstrating it step by step. Could we talk to our anesthetist? What were the challenges in this patient?
The patient has many comorbidities. First of all, she's an elderly female, 65 years of age. She's known case of COPD.
Okay.
She's a hypertensive on treatment. She's a diabetic on insulin.
Okay.
So that was the reason we preferred to go for the open surgery in the patient, and we did intubated the patient. We gave general anesthesia.
Thank you so much. Thank you so much, Dr. Anka. It's really always nice to work with you. Thank you so much. Thank you so much.